Going to master class. Now I request Dr. Harishankar Pato, who is the governing body member and immediate past chairman of the API West Bengal branch, to introduce today's chairperson and the subject, if he thinks. Harishankar Pato, please.
Good morning, everybody. At the outset, I thank Dr. Amal Kumar Banerjee, Chairman of Indian College of Physicians, Forum West Bengal, for giving me this opportunity to introduce today's chairperson of the master class, Dr. Pratik Kumar Das, today. I have pleasure to introduce Dr. Pratik Kumar Das, who is a very renowned nephrologist. He has done his MD and DNB nephrology, and he is now one of the finest and excellent teachers in nephrology from R.N. Tagore Hospital. He is also an examiner, one of the examiners for DNB nephrology, and I don't exactly remember the figure, but probably he has done more than thousands. He is involved in renal transplants, and R.N. Tagore Hospital being a very busy center, taking care of thousands of nephrology patients, and he is running that hospital and the department in an excellent way. Now, today's topic is urinary biomarkers in kidney disease, a very important topic. And in fact, from examination of the urine, we can have some suspicion and idea about the onset of nephrological problems. And today's teacher is also Professor Dr. Pinaki Mukherjee, who is professor and head of the Department of Nephrology. So I request Dr. Das to introduce our speaker today and also the topic. So over to Dr. Das.
At the outset, I thank to the organizing committee and Dr. Pathak for this nice introduction. And today, Dr. Pinaki Mukherjee, Professor Pinaki Mukherjee will be talking on these urinary biomarkers of the acute kidney injury. Pinaki is my junior, and he has got an excellent academic career and had done his nephrology training in PGI Chandigarh and presently working as professor and head of the department in the NRS Medical College, which is running DM nephrology program. So in next few minutes of time, he will be talking on these urinary biomarkers. As you know, the kidney, we diagnose the disease mostly by the surrogate markers, like that of creatinine, but it has got many disadvantages. So there has always been a search of a molecule which can give us an early diagnosis, its prognostication, as well as the severity assessment. So I think this discussion will be very nice and very informative. Over to Professor Pinaki Mukherjee for the further discussion.
Good morning, everybody. And thank you for the organizing committee to give a chance to share my knowledge, and also Dr. Pathak and Dr. Pratik Das for introducing me and for nice kind word. Why this topic has been chosen? Rightly, Dr. Pratik Das has said that is really we are in search of new molecules to detect the kidney injury very early. The common thought is that AKI is very common and the death rate is almost increasingly in spite of new molecules has been emerged, new way of therapeutic, new intervention has been started, new smart therapy has been given. But still, the rate of incidence of the AKI is not been increased, not been decreased, it is increased. And the death following AKI is not reduced. That is actually the problem for detection of the AKI early and intervene therapeutically and different ways to prevent the hospital mortality rate. So that is actually the search for AKI. So in my topic, I want to discuss in such a way that is why it's necessary for the biomarker study and what is the biomarker and its utility. What is the concept of the subclinical AKI and its staging? That is the new way of thinking or rationalizing the AKI. So AKI no longer than AKI, it has been started very early. The pathogenesis has been staged. So the conceptual classification has been changed. Then what is the different biomarker of AKI and his functional utility and the mechanism of the actions and the direction of the site where it actually present the whether it is a ATN, whether it is a perennial, whether it is a proximal tubular or the distal tubular, or it is a different way. And I will touch upon very little about the biomarker in the CKD, which biomarkers, which actually important, that actually give rise to the patient having a AKI, at least converted to the CKD. So you should be monitored in that particular of the biomarker to reduce the progression, at least to tell that this patient will go into the CKD. And what I will touch upon very minimal, that is the recent development for the postgraduates, because that is very important. What are the coming in a pipeline in this biomarker study? And lastly, I will just touch upon in the age of this AI, what is the machine learning and with the what is the benefit of the machine learning with this biomarker study to predict the AKI at early outset. So before starting from the main topic, I'm just giving some scenario where we come across every day. There is in a first case, that is a 60-year-old hypertensive non-diabetic patient admitted in ICU with history of acute myocardial infarction. But we have to treat this patient, and in case of the treatment modalities, whether we should restrict ourselves in therapeutic point of view. Second part, 35-year-old hypertensive non-diabetic male having a snake bite after the giving few couple of dialysis. They are apparently normal, non-oliguric, creatine come down the touchline. So should we stop his monitoring? AKI will give you the idea that is this patient will going to the CKD if it is not being monitored. Third case, a 45-year-old woman, non-hypertensive patient, non-diabetic, having a ovarian carcinoma, needs treatment with the carboplatin therapy. So should we go for the carboplatin therapy? Should we consider the dose modification, or can she tolerate the full course? That is the another scenario. Another important scenario is the patient having a decompensated chronic liver disease, having a diuretic. It was apparently it is seen that is a hepatorenal syndrome, but some biomarker study will give you no, it is a not hepatorenal syndrome. It may be some other cause that actually underlying in the main diagnosis of the AKI. And then another last case, that is we are come across the patient in a pediatric subset, the pediatric age group, the old 10 years old boy having a pneumonia or the sepsis in the pediatric ICU, and we see in many of these patients they can need some aminoglycosides in a sepsis ICU setting. Whether that particular scenario, particular antibiotic can be given, or those can be modified, or you can alter the medications. So all of these 5 cases, if you see, that is all these things, some early study of the biomarker, it is really predictable. Not only predictable, it can lead to the therapeutic intervention, changing therapeutic intervention, and ultimately you can prevent, or it can reduce the incidence of the AKI in your normal settings. In the first case, if you see, the urine NGAL level was a little bit of 5 in the cutoff level, and when it was continued after the primary angioplasty, creatine was high, and the predictive biomarker is drastically high, and the creatine was come down to the 3.5, that is almost 3-4 times in the 3 or 4 days of the therapy. So this biomarker study, and if you use this as a cutoff value, it will give you the at least some idea where to stop, where to start, or where to change your therapeutic intervention to reduce the AKI. In the second case as well, we have taken that is the persistently high urinary KIM, kidney injury molecule, was actually giving the idea that is the patient going to be a AKI if it is not being intervened early. And third cases, the cystatin was given the biomarker, and that revealed that is the biomarker is increasing in a setting. So this is the 5 different markers are actually given consideration, because all the markers actually signify or depict particular injury, whether it's a nephrotoxic, whether it is a septic AKI, whether it is a drug-induced ischemic component or nephrotoxic component is there. So each particular biomarker having some utility model or some predictive value for which this is being studied and that is being utilized in our clinical practice. So coming into the main topic, what is the biomarker? Biomarker is a measurable indicator of a specific biological particularity that assess the risk for presence of on stage of the disease. And another important thing is that it must be easily available, it must be organ specific, and it can present or it can depict the severity and the nature of injury. It must be a powerful and non-invasive tools, and it also enable to locate the particular site of injury that actually lead to the therapeutic intervention. So in case of biomarker injury, that is much important is that highly sensitive for the specific for AKI. It must be adequately correlate with the degree of the kidney injury. It provides the risk stratification and the prognostic information. It must be a site specific and indicate the cause of the kidney injury of the disease, and it must be relevant among the different race, age, and different ethnical group. And the changes must be rapidly and reliably in response to the kidney disease. But if you consider all the points, there is no such ideal biomarker available today, because all the biomarker have some limitations. So now the new concept coming out, that is the multiple biomarker to get a much more better negative predictive value. So traditional biomarker was actually thought to be the creatinine and the albuminuria, but creatinine is raised in a very long after the damage or the injury occurs. So creatinine is no longer a good biomarker for depicting your loss of GFR or the acute kidney injury. And also the albuminuria is not the biomarker, because this albuminuria, though it was increased, but it does not decrease or does not changes according to the severity of the AKI. So creatinine and albuminuria is no longer a good and justifiable biomarker. What are the limitation? Limitation is that creatinine is affected by the extracellular volume depletion. It depends upon the age, sex, body mass index. It reflects the loss of glomerular filtration function and development of AKI, but not specific renal tubular lesions. It represents basically the glomerular portion. But if the tubular functions is deteriorated, like nephrotoxic ATN or the septic ATN, they cannot actually represent as part of the extent of the injury. And another important factor that is not for which actually creatinine is not good for the representative of the AKI, that is interaction between the drug like cimetidine, trimethoprim, that cause decreased secretion and increased serum creatinine. And another important thing is that changes in its concentration is neither sensitive nor specific in response to the slight GFR changes. That is very much important for detection of the AKI in early stage. So this is the pictorial presentation. It's a very common pictures to all of the general physician, interventionist, nephrologist, and the medicine specialist. That is how the biomarker study has been done and how they are actually effective and helpful, and which particular biomarker should be studied or should be taken for in a particular subset of the AKI. So whenever the GFR is concerned, that is the podocyte count, urinary albumin excretion ratio, or in the serum creatinine is the good. That can also reflect the loss of GFR. When the proximal tubule is actually the part of injury, there is the urinary interleukin 18, urinary kidney injury molecule, and is a major and mostly studied biomarker. But other biomarker is also the much more sensitive, like urinary NAG, urinary natrine or all the alpha-1 microglobulin, but they are basically for the research purpose. But we are not practice in a very clinical practice or day-to-day practice. The same thing, there is a distal tubules functions. It is actually predicted by urinary in Engel and urinary, that is the pi GST, and interstitial fibrosis actually look for TGF beta and the collagen 4. So I'm not going into the complicated part, but it has been studied in a multiple way to assess the diagnosis of the AKI, to predict the severity of the AKI, to predict the need for the renal replacement therapy, and the patient which is going to be the AKI to CKD conversion. So in this way, all this model, they have studied this biomarker extensively. So why such complication is there? But still, even in this complicated way of searching of these things, that is, all the biomarker is not being actually representative of the particular AKI, because AKI pathophysiology is very complex. It is not in the straightway pathway, or it was been taught earlier. So in this pathological process, the new concept that is coming, that is the AKI, when it is being established by the decreased urine output or the starting of the rising of the creatine, it is too far away, and where the damage is persistent and damage is sometimes is irreversible. So when the person at risk, or when the person, some nephrotoxic drug need to be given in a particular setting where they can cause AKI, the starting of the AKI classification is started. So AKI classification is now being changed in a more stress of given in the subclinical AKI. So for overall teaching, what happens in the AKI, there is a vasoconstriction, disconversion of the tubular cells, interlobular tubular construction, local production of the inflammatory mediators, and that ultimately leading to the AKI. But when the AKI already been established, so then when the recovery stage, there is some efficient tissue repair is there, regression of the injury is there, majority of the patient is actually recovered from his injury or the stress factor. But some cases where the faulty repair process or the extent of the injury or the type of the insult, that actually not reversible, that is called inhibited tissue repair, that lead to the acute kidney disease. The new term is called acute kidney disease from the AKI, and that lead to the progression of injury, lead to the CKD. So that's why the this picture beautifully present where actually the biomarker is utilized and what is the biomarker is needed in the day-to-day practice, just to not only to early diagnosis, to intervene the AKI, and to start the therapeutic options to decrease the AKI and to decrease the mortality following AKI. So if you see in this A, there is a reversible element. When the normal kidney is at risk maybe in the nephrotoxic drug, in a septic AKI setting, or drug induced or the contrast induced, so there is always at risk. If the patient is at risk, then that biomarkers identify the susceptibility. So particular biomarker is, if it is raised from the very beginning, then you have to stop. You have to consider this patient at risk, then you have to monitor, measure, surveillance as a way, that is, it cannot go further way. So biomarker study is very important in this stage. Then when the risk is there and it is sustainable, when particular there is a cardiopulmonary bypass surgery is there, or if the contrast is given for the life-saving measurement and it is a persistent, so then the damage occurs. But this damage is not reflected by the decreased urine output or even in the decreased creatine, raise of creatine. So in this type, biomarker identify the injury mechanism and the target, whether it is a proximal tubular, distal tubular, or it is a combination. So this is the one place of the biomarker that is give you the idea, the actually basic pathophysiology. And when this injury is sustained, even in this that stage, then ultimately the GFR started to decline. That is actually the clinically we call is a AKI. That is when that is a creatine is started to rising from the baseline value, and also it is urine output is started to decline. But this is too late, because majority of the reserve, that is called reserve mass or reserve nephron, are affected, and they may not recover fully when the particular therapeutic intervention has been started. So that is actually the diagnostic criteria created and all the different way, that is the Akin criteria, KDIGO criteria, rifle criteria. There are a lot of criteria. Now they have been started because of identify the AKI from the very beginning and to predict the mortality and the progress of the AKI in a subsequent events. So in this way, the biomarker has an immense value to confirm the diagnosis. But still, after the AKI has been subset, even in the later also, the biomarker has an immense value. Why? Now, which group of AKI will go into the CKD? Which group will require the RRT? Which group of AKI is not required, that is not amenable for the treatment, or when poor amenable of the treatment? That also can give rise predicted by the biomarker. So you see, from the normal to the renal death, because all the aspect, there's some, in some cases, there's a reversible element. There's a reversible element. So you can put your biomarker and you can intervene adequately, you can reverse the situation. But when actually the GFR is going to decline, it's called irreversible state. You cannot reverse the things. So biomarker study is very much important. Just predict this AKI, diagnosis the AKI early, and early therapeutic intervention to prevent ultimate the renal death. This is the same type of pictorial presentation, just showing importance of the biomarker study for the differential diagnosis, early detection, and also the prognostication of the cases. So this is the new concept for the biomarker. That is why in early staging of the AKI, what marker actually is important to identify that AKI early. So this group of marker is called stress marker. This stress marker basically reflect the cell stress, which may resolve or become aggravated. So among this stress, there is a very important, because they can predict AKI very early. That is DCOP3, tissue metalloproteinase 2, and insulin-like growth factor, and the binding protein 7. Because we are very much concerned about the early diagnosis. And later on, when the stress is going on and susceptible to the particular insult, so they call it damage. So this is a damage marker, indicate the structural damage that may or may not the result in the reduction in the renal function. So our aim is to not to go to the damage part. So you have to intervene in the stress marker. So even in the patient in the damage marker, there are molecules that we actually commonly see. That is the kidney injury molecule, or interleukin 18, NGAL, and other factors like there. But there are some smaller study for the research purpose. And functional marker is the ultimate marker. It's called creatinine. When the damage is persisted and when actually kidney is going to be die. And functional marker correlates with the alteration in the glomerular filtration only. It cannot depict the tubular dysfunction. So considering these biomarkers together can offer a precise approach beyond the measuring the serum creatinine and the urine output alone, may suggest the most accurate diagnostic and the therapeutic modalities. Then why the biomarker is increased in the plasma or in the urine? The common consensus guideline that is the biomarker that is actually predicted the kidney injury molecule, they have some external sources. They are increased or they are secreted even in the common insult in a kidney or the liver or the heart. So first important thing is that plasma biomarker is increased due to the increased synthesis of the biomarker in the external tissue or release from the circulating immune cells. And some biomarker much more predicted increase of the urinary value. So that is basically for the much more glomerular infiltrations, impaired reabsorption in the proximal tubules, or increased synthesis in the tubular cells, or release from the infiltrating immune cells. So some biomarker who are being filtered in the glomeruli, both biomarker either urinary or in the plasma, both can be increased. But some biomarker much predicted in the urinary, some much predicted in the blood level. So what is the clinical need? Clinical need is when are biomarker needed for the risk assessment, recognition, differential diagnosis, or targeted intervention, and to predict the prognosis. Which biomarker should be measured? That is that is stress biomarker, damage biomarker, or functional biomarker, or in a combination biomarker coming later. And how should result is interpreted? Must be result interpreted the predictive value or odd ratio or the area under curve that is actually predicted particular biomarker that has been given, and something is available in the commercially as well. And how should data use? Should be used data in the clinical basis or data basis setting. And this is a very important things that is for the concept of the biomarker study in a case of the AKI. If you see this patient is this kidney is the normal. When this is increased risk, two things happen. One side, there is a damage occurs. The nephrons are basically at jeopardized. Nephron are at stress, or if the nephron mass is considerably decreased, then the GFR is starting to decline. So this is the only the part that is you have to consider the AKI, not the beyond that. But in clinically, that we actually see these things when the GFR is declined and when the GFR and damage is there, when the creatinine is creeping high, that is actually the we come into the notice the patient is suffering from the AKI. But nowadays, this part is much more important when actually the stress factor and the damage part is there, which ultimately lead to the kidney failure and the renal death. For this, just to reduce the mortality, to diagnose the AKI early and to diagnose the AKI in the different subset in the different clinical etiology, there are a lot of diagnosis, a lot of definition has been almost 52 definition of the AKI has been published. And if you see, initially it was called acute renal failure, then it comes to the acute kidney injury, then it comes to the kidney attack, and then it comes to the acute kidney disease. So many cases, many study people, they have seen in the mortality benefit, they have seen the progression of the AKI to CKD, they have seen the intervention. So in this way, they have changes the guideline, and they are staging the AKI according to their etiological basis or in the basis to prevent the mortality or death or to prevent the surrogate progression. The common KDO guideline that is much more sensitive and highly predictive for the last 7 days of the hospital mortality. They have 3 staging: stage 1, stage 2, and stage 3. Stage 1 is 1.5 to 1.9 times or more than 0.3 milligram per day increase in the creatinine from the baseline. Stage 2 is there 2 to 2.9 times, and stage 3 is more than 3 and more than 4 milligram per day or requirement RRT. This is the one way of diagnosis of the AKI. So, in retrospectively, AKI has been classified in the different way to see if this criteria is been followed. Is the outcome is predicted from this staging 1 to 3? Because as the stage 1 is stage 2 is worse than stage 1, stage 3 worse than stage 2. So in this way, retrospective diagnosis of the staging of the AKI is there. Then what is now concept is that the recovery. If the patient is recovered early, the nephron mass is preserved and the kidney recovery is much early, is the less chance of AKI to CKD conversion. So in this way, AKI is classified in the early recovery AKI and the delayed recovery AKI. So early is diagnosed when is early, there is a less than 48, early in the chance of the improved urine output or the decline in the creatinine which was raised or the biomarker based improvement in the early, and delayed is that is the 48 to 7 days. Within a 7 days is called delayed. But in some certain cases where still the urine output is not improved or the creatinine is not come down to the baseline level, but still patient is improving, that is actually called the AKD, acute kidney disease. So in this group, that is the AKI is persisted more than 7 to 9 days. And this AKI group is actually much more vulnerable and they are very much propensity to chance to go to the CKD. So we have to very much careful and in this group of patient. In this AKD group, where actually persisting the kidney injury within 7 to 9 days, there is a stage 0, stage 1, stage 2, and stage 3. Stage 0 OKD, basically the no evidence of injury, but biomarker loss of kidney reserve is there, is persistent. The biomarker is not being come down to the baseline level, called stage 0 AKD. Stage 1, stage 2, and stage 3 depending upon the creatinine and the requirement of the RRT. And when the same creatinine value or some persistent proteinuria or the biomarker, uprise biomarker persistent, even in the beyond the 19 days, then we can call it as a CKD. So that is the point, is AKI to CKD conversion. So I am not going to the details, the different definition in the criteria, but this different type of criteria has been based on two major effects. That is the outcome, hospital mortality, and also the which is propensity for the much more specificity, sensitivity in the early diagnosis in the case of the AKI. So Akin and KDIGO, that is the basic difference is Akin actually looked up only 48 hours of the AKI and their outcome, but KDIGO, they have seen that 77 days of the AKI and their outcome. So in this way, much more specific and sensitive in the KDIGO guideline. So now I'm just discuss very nutshell in the few biomarker which is very commercially available and sometimes is important for the research therapeutic tools, and which is one should know in case of day-to-day practice or therapeutic purposes. I'm not going to details in individual biomarker. The first biomarker that is very much important and very common to both of us in the critical care practice, in neurologists and nephrologists and in the medicine care specialty, is the NGAL. That is the neutrophil gelatinase associated lipocalin. It is also known as lipocalin 2. It is a glycoprotein bound to matrix metalloproteinase 9, and it secreted by immune cells, hepatocytes, and the renal tubular cells. And NGAL acts as a growth and the differentiation factor in the multiple cell types, including developing and the mature renal epithelium. And it actually depicts the thick ascending limb of the loop of the Henle and the intercalated cell of the collecting duct are the primary site of the NGAL production in the kidney. So whenever there is an ATN is there, and mostly the nephrotoxic and ischemic ATN is there, NGAL is raised in a considerable amount. And what is the beauty of the NGAL is that it elevates very early. It detected as early as 3 hours after the insulted injury. So this is one of the biomarker that is being studied extensively, and is the earliest biomarker to representing the tubular injury and for the diagnosis of the AKI. So increased NGAL expression is significantly associated with the developmental AKI, mostly in the ischemic, septic, and post-transplant AKI, in a special setting in the cardiopulmonary bypass surgery, or in the STEMI in the coronary intervention, or in case of the decompression cirrhosis. These are basically the setup where NGAL is actually proved to be a very much good biomarker in comparison to the other biomarker, and they have very high predictive value, and AOC under the curve is very considerable amount. So another important biomarker is the interleukin 18. Apart from this GFR, there is some inflammation is there. Inflammation is the cascade, which actually the one of the important pathophysiologic part of the AKI. And interleukin 18 is actually represent the inflammatory marker, and but very much pertinent to the proximal tubules, and patient with ATN in the kidney transplant recipient or delayed blood function when the kidney in the disease donor program, or the patient of the situation where the ischemia perfusion injury is there, or in a case of nephrotoxic drug like cisplatin induced therapy is there. Interleukin 18 shows promising biomarker to not only detect, it also can predict it, the severity of the disease, need of the RRT, or this patient is going to be much further hospital stay. So interleukin 18 not only the diagnosis, it also the prognosticate the things. And kidney injury molecule is another important molecule, and it is nowadays called troponin of the heart disease. Just that is the troponin is a very useful marker. In case of the AMI, it is increased, it persists, and it can also prognosticate the patient. Patient comes to the eye. The problem is that in the kidney injury, there is no pain. So patient is very silent and very transient. We don't know the injury started when the actually kidney is being injured or at fault. that is the difference between the kidney biomarker and the heart biomarker. But in ideally, kidney injury molecule is regarded as the troponin of the myocardial marker, and is a type 1 transmembrane protein, and is a mainly depict or represent the post-ischemic injury in the proximal tubules, readily detected using the urinary dipsticks. And another important thing is that this is not only the diagnostic marker, it is a prognostic marker, and it can cause the AKI to secretory conversion, because the kidney injury molecule that is raised from the very beginning, but it is not coming down to the baseline. It is a persistent. So it is even in the creatinine normal or urine output is adequate, these patients need to be surveillance, because there is a very high chance of the patient to the AKI to secretory conversion. So kidney injury molecule in the every aspect is a complete, one of the complete biomarker in sense. And another 2 or 3 biomarker, though it is a very promising, but it is not used in commercially. It is a proximal, that is a liver type acid binding protein, only in the research purpose or to compare or to binding the different biomarker. It is used in the different subset. It can predict the susceptibility of the AKI, and biomarker to predict renal recovery. That is the beauty of the liver type acid binding protein. And kidney transplant recipients, where actually the has been noted strongly correlated to the ischemic time, and has thus been proposed to be a marker of the kidney hypoxia. Suppose the patient is need to be diseased donor kidney. So that study of the liver type of acid binding protein that will predict the ischemic time of the particular, and this is called the marker of the kidney hypoxia. Then another important part actually came to the market, that is called NephroCheck. There's a 1 or 2 group study. They have shown that is the combination of the marker have immense predictive value, and they are very much informative and diagnosing, and also interpreting the progression, need for RRT, even in the deaths can predict. So there, among all these biomarkers, 2 has been chosen and actually selected, and there has been a trial in a human trial as well. That is insulin growth factor BP7 and the TIMP. Both are basically combinationally have good marker in spite of the individual marker. There are 3 landmark studies, there is Topaz study, Safran study, and Nobel study. They have shown the benefit of the combination diagnosis, and now it is being marketed. And another few markers that I'm going to touch upon these things for the only the therapy, there is an academic purpose. That is the calprotectin, that is differentiating the prerenal from the impinging AKI, and it is increased in the several conditions, including the rheumatoid arthritis, inflammatory bowel disease, urinary malignancies, and urinary infections. So it is may not be the much predictive of the only the kidney injury. And another form of biomarker, basically the urinary enzymes and urinary proteins that is synthesized in the surface cell line. Urinary angiotensin is basically biomarker for AKI progression in the acute decompensated heart failure. And another very important part, that is called urinary microRNA. That is actually the future biomarker study. MicroRNA is endogenous non-coding RNA content 18 to 20 nucleotides, and they utilized in the predicting AKI, because even in the injury started, this microRNA study give you the idea that is this patient is very much prone for going to the AKI. Well studied biomarker is the cystatin C, but the it is secreted in the proximal tubules. It is not being absorbed, not being actually filtered, and it is very much representative of the decline in the GFR. And what is the importance and difference between the creatine and the cystatin C? Creatine is dependent upon the muscle mass, but in the cystatin C, though it is a good marker for the GFR, it is independent of the muscle mass, but it is not being so much used as a very useful biomarker now. And the 2 important biomarker that is also coming into the very big way, that is in the representing the proximal renal tubular changes, that is the gamma glutamyl transpeptidase and the aminopeptidase, and some urinary low molecular protein like beta 2 macroglobulin and the alpha 1 macroglobulin. They represent the tubular injury. This is another concept now coming out. There is any biomarker is not ideal in all aspects, and there is an external synthesis or external availability is there. So combination biomarker is representing the much more earlier, and it representing the particular site of injury with a much more predictive value, and also it representing the therapeutic intervention and the outcome in the terms of death and also AKI to CKD conversion or the renal death. So commonest combination biomarker that has been shown, that is a KIM1, NAG and NGAL, evaluate early detection for the post-operative phase. Urinary NGAL and urinary KIM1 predicted composite outcome in dialysis initiation or the death during hospitalization. And NGAL, interleukin 18, KIM1 and alpha fatty acid binding protein was actually studied in the cirrhosis and AKI. So in this way, you have to justify your situation, and you have to select particular biomarker maximum. So there is some genetic association also for this biomarker, because which patient is going to be AKI much more prone, which patient even in a very small or mild injury much more severe AKI, we don't know. Even some animal model also, they in a study, some protocol, some biomarker, some behavior cannot match with the particular when this trial is going on in the human model. So only because of some chromosomal influence on the human model. So chromosome number 4, APIL1 regulator IRF2 has been studied. Some TNF gene was actually identified, and some nuclear factor of kappa light chain on polypeptide gene also actually shown to be influenced on this, the biomarker or association of the AKI and these progressions. There's another important part that is we use in practice every day. That is, if the patient is actually going to be AKI or it is a very at risk factors or the urine output is temporarily withheld, we use the fusamide test. What is fusamide test? That is, if you give 1 milligram per kg in the fusamide or 1.5 milligram in the non-naive patient, and have to check whether urine output is improved or not. If the urine output is improved, the more than 200 ml within 2 hours, so that indicate that is the reserve is there. Even patient is non-oliguric state, is less chance of the death, less chance of the progression, and it can assess your kidney reserve. So on the same basis, there is a AKI staging is little bit changed, and in 2020, JAMA, there is one publication, the AKI staging on the basis of the biomarker. They have been studied in such a way that is in a stage 1S, where the patient is only the susceptible. That is, the creatine is normal, urine output is normal, otherwise patient is fine, but biomarker is going to is an increasing trend. So this is called biomarker positive. It's called 1S. And combining with the Akin criteria, KDIGO, that is, they have combined these things. That is, rise of the creatine is 0.3 milligram per day in less than 48 hours, or 150% in less than 7 days, or urine output is less than 0.5 ml per kg for 6 days. That is called stage 1. That is definitely there is the stage 1 of the Akin and KDIGO as well. But the difference is that they can differ in the stage 1A and 1B. The situation where the biomarker is positive, they are actually keep the stage 1B biomarker positive stage 1 AKI, but where the biomarker or particular biomarker which is actually taken into the account is not predictable or not increased, called biomarker negative stage 1 AKI. In this same way, there's stage 2 and stage 3. All the AKI criteria that has been taken from the KDIGO or AKI, that is more than 200% of the serum creatine is increased, or decreased urine output, that is less than 0.5 ml per kg per hour, more than 12 hours, they are stage 2. And whenever there is a more than 300% or more than 400 that is a more than 4 milligram per DL, or patient is anuric for more than 12 hours, they are at stage 3 or advanced AKI. That is the AKI which actually we start the RRT and the patient is required dialysis. And this is the staging where much more AKI to AKD conversion is there. So biomarker study is immensely helpful to intervene the situation. So there are some study, I'm not going to details, that is the urine NGAL and interleukin 8 show promise in a early AKI in the children subset. NGAL is very much utilized in case of the cardiac surgery bypass therapy in AKI, and also the NGAL having the injury facility, the early diagnosis in a implement the therapeutic adjustment. So these are the old paper, but still have had the new and the thing is that cystatin C, interleukin 18, Kim 1, much more important is that. So these are the biomarker are basically important for your clinical practice. So I will not go details in the biomarker in the CKD, but I'll touch upon the CKD biomarker, that is clinical practice glomerular filtration rate estimation and albuminuria are the widely used for the CKD diagnosis and the prognosis. And if you see in this scenario, you'll see there are some biomarkers are depending upon the marker of renal glomerular functions, marker for endothelial dysfunction, marker for tubular injury. There is some metabolomic profiling is there, some marker for inflammations. But all the marker has an individual perspective and individual way of your cutoff value that can predicting the AKI to CKD conversion. But in nutshell, the main urinary biomarker that were found to be associated with the progression of the CKD are DKK3, LA-APIWB, and uromodulin, and the CKD 273. In case of CKD 273, a new player of the field and has shown very promising result in the diabetic nephropathy, and is a proteomic based classifier consisting of 273 urinary peptide and can detect diabetic nephropathy years before the development of the microalbuminuria. So these are the actually the new development in CKD. So nevertheless, uromodulin is the only protective biomarker, which means that it elevates the level of associated with the better kidney health. Combining the DKK3 with the protective biomarker like uromodulin could lead to increase the sensitivity for the AKI to CKD conversion. So I will touch upon some recent advances on the biomarker on early and the late kidney graft. I have already said that is the microRNA is a very promising one. Serum microRNA being explored in patient with AKI, and it is being utilized in the transplant setting as well. But apart from that, there is some proteomics or the metabolomics is there. Some extracellular vesicles, urinary vesicles contains proteins from various nephron segment, and that also may be utilized as a part of the early biomarker, and also the biomarker for the inflammations, that is plasma interleukin 6 and interleukin 10. So this is the very small subset, but it is a very much promising biomarker in a transplant setting. It is called multicenter validations of the urinary CXCL9 as a risk stratifying biomarker for kidney transplant injury. So if the patient is a rising or creatinine in a post-transplant setting, so some biomarker that can predict the rejections, like FOXP3, CXCL90 is very promising, and that is actually very high predictive value or at least negative predictive value for the rejection purpose. So sometimes before biopsy, we can take the decision for the intervention in a transplant setting as well. There are new way of actually finding out the urinary biomarker than extracellular vesicles. Actually, extracellular vesicles from all cells, healthy or disease, the vesicles is there, ectosomal or endoplasm, and these vesicles containing the protein, lipid, nucleic acid, and the mRNA. And this is actually the facilitate the intercellular communication, and it found in the different fluid and including urine. So that is from the urine, as it is the early part, these vesicles can be collected and it is processed, and the proteins, lipid and nucleic acid is being measured, and they are assessed and to find out the cause. Like it is called the liquid biopsy. And another is called the urinary exosome mRNA signature for rejections. This is another way that is, as it is called, the urine is called the liquid biopsy. But urine has a lot of things for the enzymes, its proteins, its microRNA, vesicles, or a lot of new molecular, new tubular proteins that actually give rise to the representation of the injury, pattern of injury, and it is can signify whether this pattern will be persistent or can lead to the AKI to secondary conversion. So urinary exosome mRNA signature is new development from the extravesical cells, and that rightly predict the rejection in a transplant setting. Now, next, this comes according from the biomarker, risk prediction tools came in. The results of the targeted analysis using the SomaScan proteomics platform indicate the novel association of circulating proteins with the risk progression of the kidney failure in diabetes. So this is another kind of the new development in the biomarker study. That is, you are studying the different proteins that is actually predicted or can be associated with particular disease process, either in the AKI or the diabetic CKD or any kind of the rejections or the gut functions. So in this protein, what happens? The 11 proteins are being implicated in the kidney fibrosis or the renal development. Their values is targeted in the renoprotective therapies need to be studied, and using this regression analysis, 5 proteins have been selected for actually the high predictive value called LAYN, SAM, DLL1, and MAPK1 and the endostatin, and were found as possible prognostic biomarker to assess the ESKD risk. And finally, that is in the age of this AI, artificial intelligence, that is the machine learning is another way of predicting the AKI. That is initial validations of the machine learning derived prognostic test. It's called Kidney Intel 9, integrating the biomarker and electronic health record data to predict the longitudinal kidney injury. How it happens? They have given that is the two subset very interesting thing. That is two cohort has been studied. One cohort having a type 2 diabetes, and one cohort that is the normal patient but having the APIL1 risk genotype. But basically, they are very much prone for AKI, and they are studied with this machine learning with the taking the biomarker as a tumor necrosis growth factor as a chronic biomarker and the kidney injury molecule as a acute biomarker, and they have studied and following the cases, and at the end of the study they have shown that in patient with the type 2 diabetes or APIL1 high risk prognostic test, that is kidney, there is a Kidney Intel X integrating the biomarker level with the longitudinal the electronic health recording data, and predictive value is about 92%. So many of the patients, this machine learning will predict before you going to the actual studying in the biomarker. So this is actually the latest one, how you can predict a particular injury very early with the help of the machine learning. So take home message is that the biomarker can be used as the powerful and the non-invasive tools to provide the insight into the diagnostic and the prognostic and progression. Chemo is the promising marker in the diagnosis of the CKD, whereas DKK and the uromonitoring are the promising biomarker for the CKD, and conventional biomarker has limitation. Thus, newer and more targeted biomarker are needed to the hour. Thank you.
Thanks, Dr. Professor Mukherjee, for this excellent and this is elaborative discussion. Probably he has covered all the aspects. I think it will be very much beneficial for the students. Basically, they must acquires this slide, there is a request in the question and answer session to share your slides. So I think this will be very much helpful instead of reading or going through the book. It is much more informative than that. So as there is no questions in the chat box, so I have just a question, that over the last 50-60 years, there has been no change in the mortality of the patients of AKI. If it is a community acquired, it is a 50% mortality. If it is a hospital acquired, it means almost 70% mortality. One reason being that the etiology has been changed for simple postpartum renal failure to a sepsis multi-organ failure. But there is also has been a deficit in a specific treatment pattern. There is basically no treatment for this acute kidney injury, especially acute tubular necrosis. So do you think that this biomarker can give us in future some therapeutic option which will target only the renal failure part, not per se the etiology? What is your opinion on this aspect?
This is excellent questions, because this is actually the limitation of the biomarker study. Because if you see in the last 15 years, all the groups, that is the in the KDO group, where actually the AKI study group, they have extensively studied in a particular biomarker of panacea that can predict the injury, can predict the intervention, and predict the therapeutic options. But some statistical problem is there, because some changes in the AOC curve, some non-statistical problem is there regarding the particular injury and the timing when the injury started, and where actually is measuring the actually biomarker, we cannot match. So sometimes particular biomarker, particular cutoff value cannot match or cannot justify the extent of the injury or the progression of the injury, whether injury can persist and AKI to CKD conversion will be there, or need to RRT, or patient can even in the die falling of the AKI. So all the biomarker that has been studied, apart from few biomarkers, that is KIM1 or interleukin 18, they have some therapeutic predictability, but as a whole, overall predictive value for the therapeutic option is not there. Only benefit is there if you can diagnose early. We can change our modification of the drugs. We can reduce the contrast. We can option is there to urgent monitoring, just to prevent the further progression. That is actually help to prevent the AKI for the early diagnosis and AKI to CKD conversion.
So as is another point we need to we can discuss always. Suppose nowadays when we discuss about the etiology of the CKD, other than this diabetes and hypertension, we know that AKI is an important cause for the future CKD development, because you told that there is a terminology called AKD. There's AKI which doesn't recover fully and becomes a say creatinine of 1.6, 1.9, and ultimately develops CKD with the time. So here, how do you put the biomarkers can predict such kind of patient, a subset of AKI patient whom you need to frequent and regular follow-up to diagnose them so that they are not converted to the CKD patients?
That is another important questions, because all of the nephrologists, even in the general physician, our target is to not only the prevent that is diagnosis early the AKI, to reduce the progression of the AKI to CKD conversion. So whenever the patient is beyond the 7 days, the coming to the baseline level, even the patient is already at risk. In the cases where patient is having multiple surgery or sepsis is continued, or the drugs, nephrotoxic drug in a chemotherapeutic agent has to be given for the complete cycle. In that cases, only KIM1 has some good predictive value to see whether that AKI patient is going to be the CKD, whether need for the RRT, because even in the snake bite that I have shown one case as well, in a snake bite patient, complete recovery, that is the touching the baseline level to 1.1, but still the KIM1 is persistently high. It's not in the baseline in spite of the kidney recovery. Apparently kidney recovery is there. So this patient is again KIM1 is a persistent. They should be monitored, because that is ultimately to the proteinuria in later on, and that ultimately progress to the CKD later on. So these are the group I'll actually call the AKD and KIM1 and urinary interleukin 18. they actually come to a promising biomarker to establish from AKI to CKD conversion. And another factor is the TGF beta, because TGF beta is a bipolar elevation. In case of the acute state, TGF beta is increased, but it is come down to the baseline level. When the AKI is recovered, TGF beta is come down to almost normal cutoff value. But if you monitor this TGF beta, even in the AKD group, the TGF beta is not actually touch the baseline value. They increase again when after the suppose 3 weeks or 4 weeks. So this is a second rise. This second rise TGF beta is actually the predictive value for the ultimately AKI to CKD conversion.
Okay, and lastly, another part, when we are planning for a planned event, suppose an angiogram, a CT scan, contrast exposure, or a bypass surgery. So these markers, what is your take on this? How they can predict? Because some centers, they practice there even before surgery or the procedure, they're testing these markers, and depending on that, they're deciding which contrast exposed patient will be admitted, which cardio bypass surgery patient will be put on a nephro ITU along with a cardio backup. So how this is assessment, this patient is going to develop renal failure. What is your opinion regarding it?
That is actually the beauty of the biomarker study, because all the study that has been, when the development of the biomarker in by stage 1, 2, 3, 4 and coming to the as a clinical practice, cardiopulmonary bypass surgery, pediatric ICU or nephrotoxic drugs, they have been extensively evaluated, and they have shown the patient having the older elderly age or the pediatric age group, or the patient having the underlying another kind of kidney insult anywhere. Even they have shown the NGAL is a high at the time of the cardiovascular surgery, or the dye is giving required, or some nephrotoxic drug is required. There are no other help. Then you can just this is justifiable to study the biomarker, assess the biomarker, monitor the biomarker, and they can change their therapeutic intervention according to the biomarker level, according to the biomarker pattern. But you have to select the particular biomarker in a particular setting, because all the biomarker may not be the suitable for another clinical etiological part. Like interleukin 1, interleukin 18 or NGAL is a very much biomarker in a particular subsetting. Sometimes cystatin C is the particular biomarker, or nephrotoxic. So all the biomarker is actually being evaluated is the nature of the injury, pattern of injury, and the subset of the etiology that can cause AKI.
So there are some now questions in the question answer session. Some asked that, can I prescribe routinely for biomarker test for a patient with sepsis?
No. Answer is no. Because you have to treat every time sepsis, different part. You have to use your clinical knowledge, situation, scenario. Ideally, it is a teaching, book teaching. Definitely everything is possible, but it is you have to take care of all these things. Availability, cost, and practicability, and feasibility. All things has to be keep in mind. It is not a generalized comment that in all sepsis you should do for the biomarker.
So second 2 questions are on that only. They said this is an excellent presentation, and which point of time I can order for biomarker test in a patient?
That is actually the beauty, or that is the take-home message for the study. There is a teaching. Whenever you will see, there is a 5 cases I have just started from the very beginning. That is the scenario where the biomarker study is beneficial. First is the patient having a renal, there is any kind of carcinoma, you are going to the nephrotoxic drug. There is no other way to avoiding the nephrotoxic drug. So how much, how far, and whether dose modification is required or not, biomarker study can give you a good idea, or you can alter the less nephrotoxic drug. Second thing, that is any cardiovascular surgery or any kind of cardiorenal compromised patient, where actually particular using of the dye or particular amount of the dye, volume of the dye can lead to much more progression or much severe form of AKI that can lead to the death or lead to RRT. So that biomarker study is very much useful. So we have to just judge the situation where the biomarker is basically help you to not only the diagnosis, predict or prognosticate the things, then you can order for the biomarker study.
So another question is that in a government setup where these markers are evaluated, and is there studies in our states regarding these biomarker? As already you have told that you have enough experience and studies regarding that. So is it
Yes.
done in a government setup in the West Bengal?
Exactly. We have another project in the DST project. We are actually looking for the AKI to CKD conversion in the snake bite patient. And in our cohort, actually, we are looking, that is the, when the snake bite comes, whether the patient is a dialysis required or not required, or they are other taking criteria, they actually diagnosed as a AKI. We are looking for the KIM1 liver acid binding protein NGAL, and we have seen in the 1 week, 3 month, and 6 month, and we have evaluated at least 72 patients, and in this biomarker study, and we have seen that is area under the curve. KIM was excellent predictive value to prognosticate to AKI to CKD conversion. So not only in NRS Medical College, I think in other college also some biomarker study is going on.
The another question is asking both this in the West Bengal, which biomarkers you recommend to be used by physician in the hospitals for ordering contrast enhanced CT scan studies?
Mostly the study has been done with the NGAL, because NGAL is a very much early predictive value for this kind of diagnosis to things. But KIM1 is also a promising in the same regards. So if you tell the three marker, that is the NGAL, KIM1, and the interleukin 18. And in the combination, biomarker has much more sensitive and much more predictive value. That is actually the go of the day.
That was asked by Professor Spandan Bhaduri, probably from the cardiological point of view. He's doing lots of NGOs and.
Yeah. Thank you.
And I am not seeing any other questions. So if it is so, then we can conclude the session for today. This is an excellent discussion. I think from now on, we will be seeing these diseases like not like acute renal failure and creatinine, but beyond this, an acute kidney injury with so many facets and use of the biomarkers. Thank you, Professor Mukherjee. And over to Dr. Pathak and Dr. Banerjee.
Thank you, both Pinaki and Pratik. Now it is our ritual to give the vote of thanks. I request Dr. Satya Ganguly, who is one of our course directors, to give vote of thanks.
Thank you, Professor Amol Banerjee. This talk to me is an sweet and sour sauce. The sweet part is Pinaki described hundreds of new inventions in the biomarker, so I am very much elated. But Pratik told that even with this progress for last 50 years, there is no decrease in the death rate. But we must not be frustrated. The scientists must not leave the laboratory, because if the biomarkers and cause are known, then someday treatment must come. I first thank Pratik. I had the fortune of doing work with him in Arjigar, but he has gained some weight with other gaining in life, and he's a very brilliant student. Then to Pinaki, who was my student and doing very good in nephrology. Thanks to him for this brilliant talk and many news which will be very much important for the postgraduate. Then thanks to all the audience, Professor Amol Banerjee and my friend Horishankar Pathak. Now I think that postgraduate and both postgraduate and the senior will be interested this Sunday master class, and I think everyone will be benefited from this. Thank you all.
Thank you.
Thank you, Satya Ganguly.
Thank you, sir.